Uh, dear speaker, good evening. Dear attendees, good evening. Sorry for delay for the 10 minutes because of technical issues with our computers, and we are able to fix it finally. Tonight, we'll do one of our webinar series from the Western region. Our nice speaker today is Dr. Luay Abdul Samad. He is a consultant pediatric intensivist for cardiac and medical surgical ICU, neurocritical also in King Faisal Specialist Hospital and Research Center, the branch of Jeddah. He is one of our senior colleagues who has been always supporting all hospitals in Jeddah for acceptance and referral. Decided to choose the topic of transfusion medicine and pediatric ICU mainly for packed RBC. And he will start his lecture very soon. His picture now appearing in front of us with blue eye glasses. Welcome, Dr. Luay. And hopefully the voice is clear for everyone. You can go ahead, Dr. Luay, with your presentation. You can play it now and start, please.
طيب بسم الله الرحمن الرحيم. Can you hear me, Adib? Is my voice okay?
Very clear.
طيب بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء. I'm terribly sorry for this delay, but I am very illiterate when it comes down to computers and technology, but thanks to my dear friend Adib, he took me through all the steps. So I will try to make this presentation hopefully sweet and short, because I know when things get a little bit, it takes a longer time, people get bored and get busy doing other things. And when you see these glasses, reading glasses, it tells you that, you know, this person is old. I am not old really, and I don't feel old. So, you know.
I will try to believe that, Dr. Luay.
So, when we talk about transfusion medicine, I'm gonna be talking mainly about blood transfusion. I will not discuss platelets or any other blood products, even though the other products are quite important, as everyone knows. So this is gonna be my talk. Hopefully, I'm gonna finish in about 30 minutes. Introduction, risks, physiology, literature, and transfusion guidelines, and then conclusion. So why this subject is important? In my institution, and I'm sure in so many other institutions, there is always a problem with blood transfusion or availability of blood. And I can tell you, you know, how many surgeries we had to cancel in my institution because of lack of blood availability. And every week, almost, or every 10 days, we get these emails from the blood bank begging people to come and donate blood. So it is a problem, availability of blood. Also with platelets, same problem, that there is no platelets available and the patient, some patients might be bleeding and unfortunately there is no platelets available, or their patient is undergoing surgery, cardiac surgery, or whatever type of surgery. So this is a major problem in our country and in many other countries also, availability of blood and blood products. So the question raises, how is our practice? You know, I want everyone to look at your practice and see, is this the right thing for the patient and for the institution? Or is there anything else that we can do to change slightly our practice? This is what I'm gonna be focusing on in my talk. Blood is important. Of course, it can save lives, especially if the patient is bleeding due to you know, trauma or post-operative patient or whatever the cause is. Blood is a valuable tool that we can use to save lives. And at the same time, anemia is common in critically ill patients. It is associated with considerable morbidity and worse outcome. Because, as you know, blood is important. Why is it important? It does, hemoglobin transports oxygen from the lung going into the heart, and then it is pumped into the tissues and the organs. And oxygen is important for the cells to maintain life. We cannot live without oxygen. It's important for metabolism, and for aerobic metabolism that produces energy that produces heat, make us move, and do all sorts of activities. Without oxygen, we cannot survive. So this information is well known to everyone. But the thing is, blood transfusion is associated with risks. And we always have to weigh the risks versus the benefits of giving blood. I guess the question that is very important that everyone should ask him or herself, when a nurse comes to you, or when a junior staff comes to you and telling you, oh, you know, doctor, this patient hemoglobin is 8. We should give him blood. This is always every day. It is almost every day someone will come and ask you that we need to give blood because of hemoglobin is 7 or 8. And you need to ask yourself and to teach the people with you, what are the benefits of giving blood in these patients versus the risks and versus the implications that will be affecting your institution, because the more you consume blood, the more problematic is blood availability. And you may need, and a patient may come to the ER or to the OR or the theater needing blood and it is not available. So the risks of blood transfusion, the younger the child is, the greater are the risks. So it is about 18 in 100,000 in all pediatric patients. It's about 37 in 100,000 patients for patients less than 1 year of age, and 13 to 100,000 patients in adults. So the younger the population is, the more are the risks. And look at this, up to 50% of children who are hospitalized in the ICU receive blood cell transfusion. This is all ICUs, including pediatric, adult, neonate. This is really a significant number. So the question here is, what is the threshold for transfusing those patients? Is it the number? Is it the clinical scenario, or what? When do we need to transfuse patients appropriately? What are the risks? As everyone knows, risk of infection, but now it is extremely rare because the blood is tested for most of the viruses, the hepatitis viruses, the HIV, CMV, they check for syphilis, they check for malaria. So it is quite safe, but it is still a risk when you transfuse blood. Other risks, immune-related reactions. So patients, for example, who are used to frequent blood transfusions, it can be really frustrating giving blood to these patients because finding appropriate blood to those patients can be challenging. For example, patients with aplastic anemia who's requiring frequent blood transfusions, patients with hemolytic anemias, all of those sort of things. And many of those patients, you may need to actually give them pre-medications to decrease the immune response to this blood. The other important entity here, which is related to our practice in intensive care, is transfusion-related acute lung injury, TRALI. And it is the result of the donor antibodies attacking the lung microcirculation, the white blood cells in the lung microcirculation, leading into ARDS-like picture. And this is a very significant and important risk for blood transfusion. Transfusion-associated graft versus host disease. And as you know, this is common in immunocompromised patients, patients who are post-bone marrow transplant. And it is mainly because those lymphocytes that have been transfused to those patients will attack certain organs, mainly the bone marrow, skin, liver, and GI. And that's why all of those patients should be transfused irradiated blood, just trying to get rid of those leukocytes. Non-immunologic side effects, transfusion-associated circulatory overload, what we call TACO. And this is common in patients with, for example, a patient who comes with a very severe anemia, for example, anemia of 3 or 4 or 5, and you give them blood a big amount of blood, and this can cause circulatory overload. Patients with cardiac diseases, with compromised cardiac function, the same thing. You have to be very careful when you transfuse them not to cause overload. Other non-immunologic side effects would be iron overload, like patients with thalassemia who are requiring frequent blood transfusions. Patients, for example, with sickle cell diseases who come with a stroke or acute chest syndrome, and you need to maintain them on a higher hemoglobin level, can be prone to develop iron overload. Metabolic disturbances, citrate toxicity, you know, the preservative in the blood bag is citrate for those patients. And the more you give them blood, the more is the chances of citrate toxicity. Hypocalcemia. Hyperkalemia is a very important, and it can be lethal actually. And I've seen this on a couple of occasions, that transfusing old blood, you know that the blood bank store blood for up to 4 weeks sometimes. And the older the blood is, the more will cause hemolysis to the RBCs, release of potassium into the bags, and then giving it to the patient can cause hyperkalemia. Acidosis, hyperammonemia, hypothermia, and that's why we need to warm the blood before giving it to the patients, especially to neonates, because you know their blood volume is what? Especially the prematures, for example, you know their blood volume can be 150 mLs, and if you give them 20 or 15 per kg, and the blood is a little bit on the cold side, this can cause hypothermia. So all of these are risk of giving blood transfusion. In addition to excessive use or excessive giving blood to the patients, to our patients, can cause depletion of the storage of the in the blood bank, and that can be a big problem. This graph just looks into the patients when they are admitted to the ICUs, what would be their hemoglobin usually. So they're looking into about 14 days of ICU stay. And as you can see, some of those patients, they come with a high hemoglobin, some of them are with a low hemoglobin. And sometimes because of our practice, you know, patients with a little bit hemoglobin on the low side, we give them frequent blood transfusion to optimize. And the idea is to optimize oxygen carrying capacity. Where some other patients who come to the ICU with a high hemoglobin and it drops probably because of the illness itself that is causing their ICU admission. And sometimes because of us, because we are doing too many blood sampling. And that's why it's very important that when you order blood sampling or testing of blood, how often do you really need to obtain these samples? A little bit of physiology. So as you know, oxygen delivery or DO2 depends heavily on hemoglobin concentration. As you can see from this equation, as everyone knows, that hemoglobin oxygen delivery depends on two factors, cardiac output and oxygen content in the blood itself. So cardiac output, it's the stroke volume by the heart rate, where the oxygen content is this equation. These are constants, 1.39 multiplied by the hemoglobin by the saturation plus the dissolved oxygen in the serum and the PaO2. And as you know, the most important factor to determine how much blood, how much oxygen in the blood is the hemoglobin. The higher the hemoglobin, that's the theory at least, the higher the hemoglobin, the more is the oxygen content in the blood. And hopefully the more oxygen will be delivered to the tissue. And that's why we mainly focus on giving blood transfusion to optimize oxygen carrying capacity and oxygen delivery to the tissue and to the cells. And as you know, oxygen consumption or extraction is about 20 to 30% of the delivered oxygen. Meaning, if your oxygen on the arterial side or saturation is 100%, so about quarter of that or 30% of that will be consumed by the body. And then about 70% will be returned back to the heart going to the lungs. And this is very important because if you do mixed venous sats and you find out that the mixed venous sats is 50%, so this means that your body is consuming about 50% of the oxygen. And this can raise a red flag. Why is the body extracting too much oxygen? And then you have to look into the reasons. Why is that? Is it a heart problem? Is it a pump failure? Is it a severe anemia? Is it increased demands by the body? Is it, some kind of infection? You have to look out for the reason. And at the same time, when there is less extraction of oxygen, then you have to ask yourself, why is that? Is it because of some sort of metabolic diseases that is preventing, or mitochondrial disease that is preventing oxygen extraction and oxygen utilization by the mitochondria? Or is it some kind of toxin, like in gram-negative sepsis, that is preventing this? So it is an eye-opener, and it is an indirect tool on trying to find out what the cause is. So in response to anemia, what would the body do? As you know, usually in anemia, the oxygen dissociation curve from your physiology will be shifting to the right. And this is to increase the release of oxygen to the tissues. And the body has other responses also to try to compensate for the decreased oxygen content or oxygen delivery by decreasing systemic vascular resistance. This will help to improve perfusion to the organs, to the tissues, and also at the cellular level. Increase heart rate, increase stroke volume to pump more blood and more oxygen, hopefully, to the organs and to the tissues. Here, healthy children should tolerate a fall in their hemoglobin. I'm talking about healthy patients, all the way down to 7, provided that they are not hypovolemic. Oxygen delivery to the tissues remains unchanged until the hemoglobin concentration falls below 7. This is a general rule, but of course there are exceptions. So one of the exceptions will be neonates, for example. If you look at premature neonates at 26 weekers, 28 weekers, 32 weekers, they have a limited reserve and limited capacity to increase the cardiac output, and may even decompensate when exposed to a decreased oxygen delivery. And that's why probably the neonates or the prematures will not tolerate a little bit hemoglobin on the low side. Let's look a little bit into the literature. So this is the most quoted study. It was published in New England Journal of Medicine, 2007. And what they looked at is that what would be the threshold, or what would be the best threshold for transfusing patients of blood. This is a pediatric trial. It's between the ages of 3 days up to 14 years. It's a multicentral, international, randomized control trial. It's called the PICU trial. And they recruited really a good number of patients, more than 600 patients, 320 restrictive group, 317 liberal group. Restrictive group is 7 grams per deciliter, and liberal group is 9.5 or 95 grams per liter. And what did they find out? What they found out is that 174 patients in the restrictive group did not require any blood transfusion. The patient population was patients in the ICU, critically stable patients. So a patient who comes in a severe shock or cardiac patient, these were excluded from this trial. All right, so they found out that 174 patients, almost 54% from the restrictive group, did not require RBC transfusion, where 7 patients in the liberal group, only 2%, they did not get blood transfusion. And what were the results of those patients? Multi-organ dysfunction was developed exactly the same in both groups. Death was exactly the same in 14 patients in both groups within 28 days of randomization. So the conclusion, the PICU study was that RBC or red blood cell transfusion threshold of 7 grams in stable, critically ill children significantly decreased blood transfusion by 44%. This is really amazing. if you can, I can assure you, if you can decrease the need for blood transfusion in 25% in your institution, I think your blood bank will never have a problem with blood. I can assure you that. And with this, there was no increased adverse effects in patients in terms of, as I explained, multi-organ dysfunction or mortality. Another study, this is in Kenya, 3 prospective studies, big numbers. This is not ICU patients. These are patients who are admitted to the hospital, but they had some illnesses, mainly respiratory illnesses. And they found out that the risk of death was significantly higher if the hemoglobin was lower than 5. And those patients did not receive blood. So less than 5, no blood transfusion, mortality was higher. And this is important. Maybe in Saudi Arabia, because, and in the Gulf region, you know, we are blessed, alhamdulillah, we have so many resources. And many times we order medications, we order everything without thinking about the cost. Where in other countries who are less fortunate, in Africa or in Asia, this can be a real problem. Albumin, for example, can be a real problem if you go to other countries, where here, you know, in our country, we just order albumin just like water. So you have to think about also the cost effectiveness of your therapy. Kids with cardiac diseases. Kids with cardiac diseases are 2 types. They're either blue kids or pink kids. So kids with a cyanotic heart disease or kids who are not cyanosed. And why is it important? It is important because as you can see here, yeah, this is a trial that was done by Cholet. This is 2017, published in Thoracic Surgery Journal. They recruited 105 children, less than 10 kilos, undergoing biventricular repair. So VSDs, ASDs, canals, you know, all of those patients. So pink babies, tetralogies, for example. There was 100% compliance. There are 2 groups. So the restrictive group, which is about 53 patients, did not receive blood. So hemoglobin of 7. And compared to the other liberal group, which is about 9.5. And the same thing, restrictive group subjects were maintained at significantly lower hemoglobin level with fewer RBC transfusions and no significant differences. So kids, pink babies with biventricular repair, it is, according to those studies, it is safe to restrict them from blood transfusion. If you look at blue babies, it's a little bit different because, as you know, these patients are chronically hypoxic. You know, for example, hypoplastic left heart syndrome, patients with pulmonary atresia, for example. You know, those patients, they have a low SATs. They have either a ductal dependent lesion or they're post-operatively, but they're still having low saturation. And the body, to compensate for the hypoxia or the chronic hypoxia, is that it increases blood production from the bone marrow to overcome this and to improve oxygen delivery. And that's why most congenital heart centers have adopted strategy of RBC transfusion with cyanotic heart disease to achieve a little bit greater hemoglobin compared to the other pink babies, for example. This is an old thing from the 90s. And they found out that to maximize oxygen content, you have to maintain a hemoglobin between 14 and 18. This is a little bit old trial. I don't think that anyone would aim to a hemoglobin of 14 to 18 anymore these days. Prospective studies have reported that significant hemodilution during surgical repair of infants with congenital heart defects was associated with poorer neurodevelopmental outcome. This is a long-term outcome. Another prospective trial suggested that low hematocrit during bypass can affect your early lactate, meaning, you know, a higher lactate intraoperatively and early after OR. Another trial, 2011 in pediatric cardiology. This is a retrospective chart review in the PICU. Almost 60 patients, less than 1 year, single ventricle physiology, where their charts were analyzed. They received about 183 transfusions, so about almost 3 transfusions per patient. And this is their exclusion criteria. They were divided into 3 arms. So hemoglobin, according to the hemoglobin, so A, B, and C. And these data were collected: heart rate, blood pressure, ABGs, NIRS. NIRS is a very important tool, as you know, because when you do a mixed venous saturation, you are looking to the global oxygen extraction, but we don't know really about specific organs, what's going on with these organs. For example, the brain, how much is oxygen extracted from the brain? And that's what the importance of NIRS is, that you can actually monitor the mixed venous in the brain or from the kidneys so far. And what they found out is that blood transfusions improve markers of oxygen delivery, such as arterial saturation, NIRS, when given to patients with hemoglobin concentration of less than 13. This is also another study that was published in 2013. And this is looking also into cyanotic babies, restrictive versus liberal. So restrictive, less than 9 this time, or less than 13 in the liberal group. And they found out also that restrictive strategy was not non-inferior, and it did reduce exposure to RBCs. So the data on the blue babies is a little bit, you know, it's a bit in the gray zone. Some data suggest that you should probably maintain a higher hemoglobin, where others suggesting that you will be probably okay with restricting blood transfusion for this patient and accepting a little bit low hemoglobin. So what are the guidelines in children? The guidelines in children, first of all, before I talk about the guidelines, there are important exceptions or important things that you have to think about. For example, patients with hemorrhagic shock, this rule do not apply on patients who are actively bleeding. So if you get a patient who's post-cardiac surgery, a Fontan or a Glenn, bleeding like crazy, you know, or patients with a simple VSD even, then do not think about oxygen concentration or hemoglobin number. Look at the patient, see how much blood this patient is losing, look at the clinical picture of the patient, and transfuse accordingly. Please do not wait to send a CBC to the lab and get it back, because by that time the patient will be dead. I can assure you. Do not depend on a gas or a CBC for those patients. Yes, they can support your decision, but you have to act quickly. If you have a patient who is bleeding actively, replace the blood that is coming out without waiting for, and you know, of course, you can support them with blood, FFP, cryo, platelets, factor 7 now, we are using it a lot. When there is no hemorrhagic shock, clinical picture and hemoglobin concentration is the most important marker to guide practitioners in the prescription of blood transfusion. So if your patient is not bleeding actively, look at the patient. So the clinical picture of the patient and the hemoglobin concentration would be the 2 main things that would make you decide whether to transfuse or not to transfuse. And as I said, certain groups are exempted. Those patients usually require a higher transfusion threshold. As I said, cyanotic heart diseases, chronic lung diseases, so prematures with chronic lung disease who are huffing and puffing, those patients usually require a higher hemoglobin level. Hemoglobinopathies, for example, sickle cell disease with acute chest syndrome, definitely you need to transfuse those patients. And you know, pediatric intensivists base their decision on many criteria: acute blood loss, cardiovascular insufficiency, respiratory insufficiency, failing oxygen delivery or oxygen consumption. But the most frequent reason, this is a survey study, was hemoglobin concentration. We depend a lot on it. And that's okay as long as the patient is not actively bleeding. or hemodynamically unstable, then please look at other things. These statements are based on many studies and many surveys. And what does it say? It does say that in spite of the evidence that we have, that restrictive transfusion strategy is as good as, and it is not inferior to a liberal blood transfusion, people are still giving too much blood. They are still aiming for a higher hemoglobin. Multiple surveys and studies indicate that pediatric intensivists, that's us, have only partially adopted a restrictive transfusion strategy. This is a chart. I know I'm running out of time. So I got this. This is a recommendation that came out about transfusion guidelines. And it came out 2018, and it is based on, it is like the recommendations that came out from the Surviving Sepsis campaign. This is a similar thing. A group of expertise or experts got together, they looked at the available evidence, and they stratified it according to the strength of the evidence, whether it's a strong or moderate or weak evidence. And then the last thing is the expert opinion. And they came out with these recommendations. I'm just going to go briefly. And as you can see here, I don't know if, I hope that the slide is clear, that most of the evidence is actually grade D and grade C. So we don't really have very strong evidence. So critically ill child or a child at risk for critical illness, if the patient is bleeding actively, please transfuse blood, period. Then, if there is no hemorrhagic shock, then they divided this into hemoglobin less than 5, between 5 and 7, and more than 7 or equal to 7. And this is amazing, because if the hemoglobin is less than 5, then the recommendation is to give blood. But if it is between 5 and 7, they did not say give blood. They say consider RBC transfusion based on clinical judgment. So look at the patient. What is the clinical scenario? What is the clinical status of this patient? And then according to it, decide whether to give or not to give. And then if the patient is more or equal to 7, then if the patient is not hemodynamically stable, then use your clinical judgment. But if the patient is clinically stable, look at this. General critically ill, post-operative, respiratory failure excluding RDS, sepsis, not septic shock, but sepsis, non-life-threatening bleeding, CRRT, those patients do not require blood transfusion. So equal to 7 or more than 7. Then acute brain injury, for example, consider it. Some patients with brain injury, they require a little bit higher hemoglobin. Oncology patients, of course, we transfuse them routinely, especially with patients with bone marrow suppression. And we usually aim to maintain hemoglobin 8 or above. Patients with hemolytic anemias, for example, severe ARDS, ECMO, they did not actually say to give blood, but use your clinical judgment. And then last thing is the cardiac diseases. So if you have uncorrected cardiac disease, then try to maintain it between 7 and 9. Biventricular repair, biventricular repair, no need for transfusion if it is more than 7 or equal. Single ventricle, so post-Norwood, stage 1. If it is more than 9, usually there is, and the patient is stable, then there is no need. Palliative stage 2 and 3, which is the Gillen-Fontaine. And they said if it is more than 9, then there is usually no need. And then the rest is congenital or pulmonary hypertension, use your clinical judgment. This is the recommendation. This is not really based on they have some data with a strong evidence, but some of them, or a lot of them actually is based on the expert opinion. So it is a recommendation. I'm not saying that wait until the hemoglobin goes down to 5 and then give blood or less than 5, but I think this is an eye-opener because I tell you from my own practice and many of my colleagues, our threshold for transfusion of blood is way down. I mean, sometimes we transfuse blood if it is 9 or 10, which is, I think, in my opinion, is not acceptable practice. How to avoid transfusion? So maximize preoperative hemoglobin, iron supplementation. Preoperative autologous donation. You know, the patient before the OR, they can come 3 weeks, take blood from them, put it in the blood bank, and then during surgery, give it back to them. Intraoperative cell saver technique. and tranexamic acid. TXA, there's a very strong data now that the use of TXA for patients undergoing surgeries, especially orthopedic surgery, does decrease the need for blood transfusion. So to conclude my talk, using hemoglobin values to inform RBC transfusion decision-making remains the most common factor for pediatric intensivists. Hemoglobin concentration less than 5, usually it warrants blood transfusion. Hemoglobin between 5 and 7, it is a gray zone, and you have to look into so many factors involved, and there is also a need for many studies. Hemoglobin concentration of 7 or more usually does not warrant blood transfusion, except in certain scenarios that I talk. For example, single ventricle physiology, patients with sickle cell acute chest syndrome, oncology patient, post-stem cells transplant, hemorrhagic shock, and all of these things. And this is the end of my talk. I think I finished on time, hopefully.
We enjoy your talk, Dr. Lai, actually, even if you are 5 minutes behind your time. Thank you for going over this interesting topic. Though I'm in favor of tax study to some extent, because for us and intensivists, we don't have a lot of guidelines. We have a little brave heart to wait because we have a special monitoring. We can see our patient on frequent basis. We have one-to-one nursing at bedside. They can judge us when the patient gets tachycardic or symptomatics or hemodynamically stable, which I believe a little challenging for them in pediatric ward to have such monitoring, and that's why the people is a little worried. The same thing happening for our colleague in the OR when they did the surgeries, when the non-cardiac surgery, I mean, when the kids, they are pleading for any reason, they will rush to the blood transfusion even without measuring the hemoglobin because they believe this is a safety zone for them, like the ATT for us position. So it's a safety zone. Once they saw blood running out of the patient, they'll jump on without anything. Even though there is many factors can affect the heart rate of the patient, including the pain and the procedure itself, but they look only for hemoglobin as the main factor and the main trigger. So thank you for this extensive review over the topic. I'm gonna open the mic for the questions and let's go by one. Please, who have the question, please raise your hand and go ahead. دكتور يحيى نافع أول واحد من جدة، دكتور سانتوس. طيب دكتور يحيى نافع, please go ahead. Unmute yourself and go.